Okay, great. Thank you. Thanks, Laura. I appreciate that. I can't see what you guys see, so it's really helpful to know. Okay, so like I said, our next presentation is on the study blinding procedures. So you may be wondering why we have special blinding procedures. Well, maybe not after yesterday's conversations, but just as a little bit of a background, to start, a double-blinded randomized study approach, of course, is the gold standard for medication trials. And although some participants will receive inactive medications, in this case, saline placebo, a psychological and physiological response called the placebo effect assists in the blinding process by creating some of the experiences the participant expects to happen when taking the medication. So for example, a recent review of adverse events in COVID-19 vaccine trials found that 35% of placebo recipients experienced adverse events after the first dose, which accounted for 76% of the systemic adverse events reported by all participants following that first dose. So, even though tirzepatide and saline have significantly different adverse events patterns in general, when our participants on placebo are expecting tirzepatide-like effects, they're likely to get enough of them to help hide the fact that they aren't receiving active medication. For CTN0152, however, the blinding process has been complicated by our inability to secure a matched placebo. And believe me, the team tried all the way up to Dr. Volkov. But ultimately, we were not able to obtain a matched placebo for the tirzepatide pen, nor were we able to obtain all the doses needed in the tirzepatide vials. So we will be using a tirzepatide pen and a saline vial and a syringe, which look and sound nothing alike. Because of this, the study had to develop a more complicated blinding procedure in which precautions are taken to ensure that both the participant and the study staff responsible for capturing study outcomes are unaware of the treatment arm assignment, while only the unblinded staff manage and administer the medications. We spent months considering options to somehow blind the medication itself. We looked at things like putting a blinding wrap around. When we thought maybe we could get vials, we looked at how could we put a blinding wrap around the syringe, and is there some kind of a blinding pen type thing that we can use? But again, none of them panned out. So in the end, we developed our strategy based on the strategies used by the investigators of some current double-blind studies with GLP-1 pens and unmatched placebo. So a big shout out to Dr. Lorenzo Leggio and Dr. Kyle Simmons. Developing our blinding process would have been much, much harder without their assistance. They and their teams graciously shared all their procedures, forms, and even the distraction task audio files with us. So I know they're not watching, but a big shout out to them and their teams. So let's begin with a simple overview of the procedure. In order to maintain the study blind, the blinded study team members will have access to information that could potentially divulge what each participant is receiving. So this requires a system of procedural controls, mechanical controls, and documentation controls. So let's talk about procedural controls first. Procedural controls to maintain the study blind primarily consist of ensuring that only the pharmacist or UMC sees the actual medications that are being provided to a participant. So this includes things like ensuring the placebo is maintained at the same temperature as the active study medication, ensuring there's a private, secure area for preparation of the doses, making sure that only the pharmacist and or the unblinded medical clinician handles the study medication, with no information shared on whether the medication is a placebo or active to either the participant or to the blinded study staff. Ensuring that no blinded study staff or local node staff or the lead node or blinded folks at the CCC and the DSC have access to the pharmacy dispensing or medication accountability records or to the reference sheet that indicates the assigned study arm associated with each code. We also want to ensure that the medication is transported in a blinded manner and not opened within the sight of the participant or any blinded study staff. We want to ensure that blinded study staff are completely away from the area during medication administration, because there could be sounds that they hear that would tip them off, even though they might be hearing it through the door. And a utilization of methods to prevent the participant from seeing the medication before, during, and after the injection, as well as utilizing a distraction task and auditory masking to prevent actual identification of the medication due to the clicking of the active medication pen. Mechanical controls consist of utilizing blinding procedures when storing the medication, preparing the medication, transporting the medication, administering the medication, and disposing of spent pens and syringes. So this includes things like a locked refrigerator in a secure space that's only accessible by unblinded staff and is only used for the storage of study medication and placebo. Also a locked, completely opaque box that has some sound absorbing materials in it to transport the medication. Noise canceling headphones with a pre-recorded distraction task. A drape to prevent participants from seeing the medication during administration. A locked file drawer or cabinet accessible only to the pharmacy or to the unblinded medical clinician for the storage of the accountability and dispensing documentation. And a sharps disposal system that is not accessible by blinded staff. The documentation controls involve maintaining the blind within the eClinical system during medication management and accountability practices, and ensuring that only blinded study staff perform the procedures and assessments that are associated with study outcomes. And so this may include things like randomization status in eClinical, and that's going to reflect an individual treatment code instead of identifying the assigned study arm. For that, the pharmacy or the unblinded medical clinician will maintain a secure, password-protected spreadsheet that will be utilized to determine treatment arm assignment based on the individual treatment codes. Medication management records, including medication accountability and inventory, will be managed only by either pharmacy staff or the unblinded medical clinician. Blinded staff will only have access to the blinded administration documentation for the product. So that is the SMI or the study medication injection form. The unblinded medical clinician will be involved in pre-randomization assessments, as we said, but after randomization, they will be handling the medication management, accountability, medication administration, and examination of the injection location only. They will not be involved in any assessment or activities that are associated with study outcomes post-randomization. And finally, both the placebo and the active medication will be documented as if you were documenting tirzepatide dosage levels. So, for example, if you're an unblinded medical clinician and you know you're administering placebo, you still are going to document that as if it were tirzepatide. So if the blinded medical clinician says this person should be on 7.5 milligrams, you are going to document 7.5 milligrams, even though you know it's placebo. And that will help with the blinding. Okay. Now, let's look at the specifics of blinding the injection. So first, we need to ensure that all materials necessary for the blinding procedures and the medication administration are available. And all these items may be set up by either blinded or unblinded staff before the unblinded staff arrives with the medication. It's important to ensure that the headphones and audio file are queued up and ready to go. And so I have a little bit of a sample of what the participants might hear.
Dandelion, Tulsa, Mercedes, Dalmatian, Blue, Cedar, Purple, James, Fir, California, Daisy, Colorado, Maple, Rose, Australia, Oak.
So they'll be, the participant will be hearing that for 3 solid minutes. And they will be asked to identify a particular category of words and count how many times that happens. In all honesty, we don't really care whether they count correctly or don't count correctly. But we're going to document it as, we're going to ask them, and we're going to document it as if we do care, as if this is part of the procedure. And that is the audio that's going to help mask the sound of the clicking. I think you probably could hear the clicking that's in the background of that. So again, thanks to Doctors Leggio and Simmons for those audio files. And
the DJ who created them with the clicking sounds.
DJ, yes, whoever that random DJ is, they did a really good job. And just in case you're wondering, all of the audio files are slightly different. They don't all sound exactly like that. They all have the clicking and they all have music. Some music is kind of upbeat, some of it is kind of funky, and some of it is just a lot of noise in the background with the clicking and the words being scrolled over that. So lots of different audio files, so you'll need to make sure that you have the correct audio file for the visit queued up. All right, so I want to say another thank you. The study team at the Marshall site in this study has graciously prepared a series of short videos, and that is going to help us through the next steps. So let's go.
Dandelion.
Not you. All right, let's hear what they had to say about preparing the participant.
Following randomization, the participant will be taken to the exam room for injection. The blinded staff, or in our case the research coordinator, will allow the participant to get settled and discuss the blinding procedures. The research coordinator will describe all the blinding procedures to confirm that the participant is comfortable with the procedures and knows what to expect from the process once the unblinded staff enter the room. The research coordinator can demonstrate the draping and audio file with the participant prior to the unblinded staff entering the room to ensure the blinding procedures will not be unsettling for the participant. Once confirmed, the research coordinator will proceed to the audio task instructions utilizing the script provided. The research coordinator will then set up the attention task in the attention task log. The research coordinator will then enter the date next to the correct visit on the sheet, verifying the correct audio file to use. The research coordinator will confirm that the correct audio file is queued up on the tablet and remind the participant which category they will be counting during the attention task. Once the audio file is chosen, the research coordinator will provide headphones to the participant to place over their ears and test to ensure that they can hear the audio file but not the research coordinator's voice when speaking at a normal volume. If needed, the research coordinator will adjust the volume as needed and then reset the file to the beginning of the audio track. Once the audio track and headphones are ready, the research coordinator will ask the participant which area they prefer for the injection and, if appropriate, the research coordinator will ask the participant to expose the preferred area. The research coordinator will remind the participant that the unblinded staff will tap the preferred area when the injection is ready and for the participant to give a thumbs up when they are ready to receive the injection. This is a good time for the research coordinator to pause and ask if the participant has any questions or concerns before starting. For the first injection, the research coordinator may consider briefly introducing the unblinded staff to the participant to aid in the participant's comfort before placing the drape and stepping out of the room. The unblinded staff must ensure the blinding procedures are maintained during this time, and neither staff nor participant are accidentally unblinded. The research coordinator will then place the drape on the upper chest and over the shoulders to block all sight from what is happening in the room. Once the unblinded staff arrive, all blinded staff in the area must leave. The research coordinator will place a do not enter sign on the door, ensure all blinded staff have exited, and shut the door behind them. Following random
Okay, so we prepared the participant. Now let's prepare for the injection.
The medication prepared by the pharmacy or the unblinded medical clinician must be completely out of sight of any other staff when moving between the storage area and the injection administration area. For this, unblinded staff will place the medication, either a tirzepatide pen or a vial of saline and a syringe, inside a hard-sided, opaque, locked transportation box similar to the one seen here. In addition to the medication, it is recommended to include a small opaque sharps container or some other kind of opaque biohazard material disposal method so that the spent medication can be safely transported back to the secured area for disposal in a way that both blinds the product and protects the staff from accidental needle stick. Each site should ensure that the procedures selected for that site and outlined in the site's standard operating procedures are in line with local safety requirements. In addition, it is important to utilize sound muffling material such as clean paper toweling, bubble wrap, or a chuck around the medication to prevent it from rattling around and potentially unblinding personnel and participants by the sound made when carried. The unblinded medical clinician will also bring the medication accountability log associated with that dose secured in a large manila envelope to prevent blinded staff and participants from seeing it. The medication prepared by the pharmacy
So we will talk more about the injection itself in a different presentation, but there's a few things that I'd like you to keep in mind during the injection. So first of all, maintain all medication and accountability logs out of the participant's line of sight at all times. And as you heard in the video, he talked about putting them in a large manila envelope that only the unblinded medical clinician handles. Second, there's some timing differences in preparation and administration between the two products. So thinking about this, the placebo is going to take longer to prepare than the tirzepatide pen. So we're asking the unblinded medical clinician to count to 30 between determining that the participant can no longer hear them and preparing the site with the alcohol pad. As the tirzepatide requires the needle to stay in place for 10 seconds, the unblinded medical clinician will count to 10 before removing the needle when injecting the placebo, again, matching the experience both in wait time prior to the injection and the actual injection time as closely as possible so that the participant can't guess what's coming based on how long it takes to prepare or how long the needle stays in. And finally, as you heard, it's important to ensure that all traces of spent medication, related trash, and any unblinded documentation are secured either in the box or in an envelope prior to removing the curtain or opening the door to allow in the blinded staff. Okay.
As noted earlier, all items must be secured prior to removing the blinding apparatus from the participant or allowing blinded staff into the room. Appropriate unblinded personnel must transport the medication box and accountability log back to the secured private area. The accountability log will be returned to its secured storage location. Medical waste must be disposed of in a way that both maintains the blind and adheres to your local agency's protocols for biohazard disposal. We recommend placing all spent pens, vials, and syringes, along with any other items with participant identification on them, inside a completely opaque sharps container, such as the one shown here. This particular container is from Uline, but you can utilize whatever completely opaque container works for you. The main thing is to ensure that potentially unblinding information cannot be seen by anyone who might accidentally walk into the area, and that such information will not be seen during the disposal process. As noted,
Okay, so you've seen about preparing the room, preparing the participant, preparing for the injection, what to do after the injection, and now let's see a demonstration again from our friends at Marshall.
the following video demonstrates the blinding procedures for the auto-injector. Once the research coordinator has guided the participant to the exam room and explained the blinding procedures and the test audio as described previously, the research coordinator will confirm the preferred location for the injection, have the participant expose the area for the injection, and will drape the participant appropriately. The research coordinator will ensure the audio file is reset and the participant is ready to proceed. When the unblinded staff arrives, the research coordinator will provide the appropriate source documents and will communicate the preferred injection site to the unblinded staff. The research coordinator will ensure that all the blinded staff are out of the area and will shut the door behind them while hanging the Do Not Disturb sign on the door. For this video, this step is done off camera. The unblinded staff will ensure the door is closed and will ask the participant if they are ready to begin. Once confirmed, the unblinded staff will start the audio file, ensuring the participant cannot hear the unblinded staff talking at a normal volume. Once confirmed, the unblinded staff will ensure all materials are out of sight of the participant and will open the transport box. The unblinded staff will confirm the medication and dose and will count to 30 prior to cleaning the area for injection. The unblinded staff will tap the participant, will give a thumbs up when ready for the injection. The unblinded staff will administer the injection, being sure to wait for 10 seconds before pulling the auto-injector away from the participant and applying a bandage. The unblinded staff will clean the exam room, ensuring all materials that could unblind the participant or staff are back in the transport box and the box is locked. Once the audio file is finished, the unblinded staff will record the reported task count on the appropriate source document and will instruct the participant to leave the bandage on for 20 minutes to ensure blinding. Once completed, the unblinded staff will leave the room, allowing blinded staff to return and complete the remaining study visit tasks. The following video demonstrates the blinding procedures for the placebo injection. As described before, the research coordinator will settle the participant into the room and ensure the blinding procedures and audio are prepared. As in the previous video, when the unblinded staff arrives, the research coordinator will provide the appropriate source documents and will communicate the preferred injection area to the unblinded staff. The research coordinator will ensure that the blinded staff are out of the area and will shut the door behind them while hanging out the Do Not Disturb sign on the door. For this video, this step is done off camera. The unblinded staff will ensure the door is closed and will ask the participant if they are ready to begin. Once confirmed, the unblinded staff will start the audio file, ensuring the participant cannot hear the unblinded staff talking at a normal volume. Once confirmed, the unblinded staff will ensure all materials are out of sight of the participant and will open the transport box. The unblinded staff will confirm the medication and the dose and will drop the placebo into the syringe, being sure to remove any bubbles. The unblinded staff will tap the participant, who will give a thumbs up when ready for the injection. The unblinded staff will administer the injection, being sure to wait for at least 10 seconds before removing the needle from the participant and applying a bandage. The unblinded staff will clean the exam room, ensuring all materials that could unblind the participant or staff are back in the transport box and the box is locked. Once the audio file is finished, the unblinded staff will record the repeated task count on the appropriate source document and will instruct the participant to leave the bandage on for 20 minutes to ensure blinding. Once complete, the unblinded staff will leave the room, allowing blinded staff to return and complete the remaining study visit tasks.
Okay, I'm going to stop sharing for just a second. Again, thank you to the Marshall team for those great videos. Very clear, very, step by step, very good representation of this sequence. And I thought maybe after that, folks might have some questions. I see a question here about medication temp logs. And the question is it permissible for blinded RA/RC to receive completed medication temp logs from the pharmacy UMC for filing in the reg binder. And I believe until the study is over, we want those maintained either by the pharmacy or the unblinded medical clinician. Mitra, do you have a thought about at what point they should go in the regulatory binder?
I don't know that we included that level of detail in the MOP, so maybe we can just email about it or chat about it offline and then give some more instruction to the sites.
Okay, that's great. Thank you. Thank you,
Mhm.
Stephanie, for the question. Any other questions about the procedure now that you've seen it before we go on?
Yeah, I had just had a thought in watching that, and it wasn't demonstrated, but I'm assuming it's okay for the unblinded MC prior to removing any medication from the box to say hi behind the curtain to the participant, because a lot of our participants have trauma, and I would think this is kind of an uncomfortable situation if they can't see the person giving them the injection, before they give it.
That's a really great point. And yes, in describing the steps, there's only so much you can put in a very short video. But yeah, it absolutely is. As long as all of the materials are out of the line of sight, the unblinded medical clinician can come in. If this is their first time, they can introduce themselves to help the participant feel a little bit more comfortable. But yeah, absolutely, they should be friendly. Now, that being said, it's really critical that they don't engage in a lot of chit chat, because particularly if the participant wants to kind of go down the road of, oh, what do you have for me today? And how long is this going to take? And is it going to hurt? And talking about the medication itself and the injection, it may be really easy to kind of slide into that with an answer that maybe gives away certain hints about what medication is coming. And, the more chit chat there is, the easier it will be for that kind of stuff to slip out. So yes, be professional, be friendly, but it's really important to keep chit chat at a minimum.
And just to clarify, the kind of packaging everything up in the kind of transport container, then you take it and you dispose of like it in a sharps container away from where anybody might be, right?
Right. Yeah. So all of these materials need to be disposed of in an area that's not accessible. I think in your SOPs, I've sent some of you some ideas on what a sharps container might be. I know there's one that I've seen that is a stainless steel container, and the sharps lid is unblinded, and it has one of those flippy things so you can't see in from the top. So putting something like that that's locked, where no one except the unblinded staff can get to it until it's time for disposal, is really critical. And, in terms of throwing stuff away, be really careful about, if you are taking off the labeling from the pen, make sure that you're not just kind of throwing that in the garbage. That needs to be in a secured area as well. Dr. Lofwell, you have your hand up.
Yeah, I was just thinking about Laura's question some more. I think it's a good point. So maybe it's something that the research coordinator is prepping the participant for also, to say, okay, so when, the clinician's going to come in to give you your injection, I just want you to know they're not going to talk a lot. They're going to introduce themselves. They're going to talk to you a little bit to make sure that you can hear them, but then they're going to very quickly start um, the audio file so that you can't hear them. They're going to give the injection and then they're going to leave the room. Like, so just so you know, it's not going to be normal for them to talk to you. It's, you know what I mean? Just to kind of prep them a little
Set
bit.
expectations.
Yeah. So that was a good question, Laura. Just Thanks. That's it.
And hopefully they get the same unblinded clinician every week so that they will get to kind of know them. So you can do it like a quick, hey, it's me, I'm John. You ready? Kind of a thing.
Yeah. Yeah, great point, Dr. Waffle. Thank you. Other discussion or questions before we move on? Okay. Well, we also want to talk about share. We also, as part of the blinding procedures, we want to talk about unblinding and how to manage those situations. So in rare cases, it may be necessary to break the blind for a particular study participant before their completion in the trial. So something may come up where they have to have, let's say, an emergency surgical procedure where it would be necessary to know what medications they're taking for the anesthesiologist, or some other medical necessity. Before unblinding, though, the investigator should consider whether the knowledge of the specific treatment would alter the participant's care or not. Sometimes folks want to know what medications you're on, but it really doesn't matter in terms of the care that you're about to be given. So when you're hearing about a situation where the breaking of the blind is requested, the first thing to ask is this going to affect the participant's care for whatever this medical issue is? If it is, then there's a procedure for going ahead and requesting the breaking of the blind. But if there's really no reason, then I think it's important for your medical clinician who's a physician to advocate for maintaining the blind unless there's some compelling reason to break it. So directions for breaking the blind can be found in the CTN0152 protocol section 10, and instructions for sites can be found in the 152 instructions for unblinding requests that's posted on the CTN website. And so you see an example of the first page of the blinding request form here. The request to break the study blind for the individual participant will be made by the blinded study physician after consultation with the lead investigators. So the first step, once you've decided it has to happen, is to contact the lead investigator, which is Dr. Winhusen. If Dr. Winhusen is not available, then other folks on the executive team would be available to help you with that and to talk through whether or not it seems necessary to break the blind. Again, just a reminder that unblinding the participant should only occur in cases of a medical emergency for which the knowledge of the treatment group or investigational agent might be necessary for clinical management and for decision making. Once you have conferred with the lead investigator or someone else on the executive team, if Dr. Winhusen's not available, then you're going to submit the unblinding request form per the instructions on the CTN website. And so here is the first page of that form. The decision for breaking the blind will be made jointly by the clinical coordinating center's medical monitor and at least one of the lead investigative team. So once you send in this form, the decision is in the hands of the lead team. After the treatment assignment for the participant is revealed, assuming that we say, yes, it's okay to break the blind, we want to make sure that the participant is continued to be followed per protocol. The treatment arm assignment would be revealed to the blinded medical clinician physician, but all other attempts should be made to retain blinding with the participant and with other blinded study team members as much as possible and that includes unblinded members of the lead team. So the actual treatment arm assignment is going to come from the clinical coordinating center's blinded team, not from the lead team. So please, once you find out what it is, please don't tell us. We don't want to know. We are blinded in this as well. So if there's any significant email communications about participant unblinding, that remains between you and the CCC or DSC unblinded teams to the extent possible. Yep. Okay, what to do for accidental unblinding? So in the event of accidental unblinding, the revealed information should not be shared with, again, other blinded members of the study team at the site. Instead, inadvertent blinding will be reported immediately to the lead investigator and the unblinded team at EMIS. But in that email, please do not reveal any information that would break the blind for others who are unaware of the breach. So for example, you could simply say there was an accidental unblinding associated with participant, say 0002, but don't include what the treatment arm was that was revealed. As this will also need to be reported as a protocol deviation, we ask again that you do not reveal any information that could break the blind there either. So once you bring up the protocol deviation form, you can say, yes, there was an unblinding incident, here's how it happened, and here's what we're going to do to prevent it, but do not say what the treatment arm was that was accidentally revealed. Once the incident is reported, then the unblinded team at EMIS, that is the CCC and the DSC, they will reach out to the site to provide instructions on the next steps. Okay, so we do have some final thoughts, and here's some final thoughts from Dr. Leggio and Dr. Simmons' Star B team.
Tips and best practices. Here are a couple tips and best practices that help us maintain the blind throughout the study. So as an unblinded clinician, it is important to avoid discussing participants with blinded team members unless it is medically necessary. This is an easy way to accidentally share information that you shouldn't. Also, it is important to be careful in engaging an injection-related conversation with the participant. They are often curious, and that is totally normal, but even casual comments can influence their perception of what they have received. Before we wrap up, I want to share a couple of examples that show just how easy it is to accidentally break the blind, even when everyone has the best intentions. We have had a few instances in the STAR-B study where blinding was unintentionally compromised. These moments became important learning opportunities for our team, and hopefully they'll help you avoid the same pitfalls. Our first example is accidental observation. In one case, members of the blinded team accidentally observed the drug. This happened because unblinded clinical staff, unaware that the blinded team members were outside of the procedure room, walked outside and unblinded the blinded staff. That is why it is essential to communicate that you are about to begin the injection. Make sure blinded team members are not in the room during the procedure room door is shut, and ensure that the do not enter sign is clearly visible on the door. It is also a good idea to have the hallway outside free of people. It seems like a small thing, but it can make a big difference in maintaining study integrity. My next example is a medication component left visible post-procedure. In another instance, a plastic cover that was part of the medication administration was accidentally left out in the open after the injection. A member of the blinded team saw it while entering the room later. And while it may not have explicitly revealed the assignment, it did introduce doubt, and that's enough to compromise the blind. This ties directly back to keeping a clean, organized workspace, especially during and after the procedure. Before the participant is uncovered, always check your surroundings and make sure everything that could reveal information is packed away and out of sight. These examples are not meant to scare you. They are here to remind us that blinding is fragile. It only takes a moment of oversight to impact the study. But with solid procedures, attention to detail, and good communication, we can prevent these slip-ups. Tips and best.
Okay, so in summary, there's a lot of things that you need to remember in order to help you maintain the blind. So number one, make sure to keep your blinded and your unblinded documents completely separated. And the unblinded documentation must be secured so that only unblinded staff can see it. Next, ensure that no blinded staff are in the area during medication management, administration, or documentation. And clearing the hallway can assist, as you heard in his example just now of opening the door and surprise, there was blinded staff standing there. Third, make sure that you're utilizing the mechanical controls, all the drapes, headphones, lock boxes, manila envelopes, and all of that stuff to prevent the participant and the blinded staff from seeing the assigned medications or hearing them. Make sure that you post a do not enter sign on the injection treatment room door. Make sure that the injection treatment room is completely free of all waste, paperwork, or medication-related supplies before removing the blinding apparatus or allowing blinded staff to enter. Avoid talk between the unblinded medical clinician and other blinded study staff about the participant to avoid accidental exchange of information that could provide a hint to the blinded staff as to what the treatment assignment is. I think it's best practice in this case to let the CRFs and the audio distraction log do your talking for you, unless something really unusual comes up that must be communicated. And finally, as you heard on this last video, avoid any casual talk about the injection with the participant to avoid giving them any hints as to what it is they might be receiving. Let me stop sharing. And my apologies. Okay, I have a couple of questions here. In the event of unblinding due to emergency, should the unblinding form be stored separately so that the node QA monitors don't see it on the participant binder report? That's a great question, Ben. And I would think yes. Mitra, what is your thought?
Trying to remember that second page. Does it give the treatment? Or is it just the request?
Let's see. No, it does not give the treatment arm assignment. So
Yeah.
just make sure that the treatment arm assignment is not documented on this form by accident. Thanks, Ben. That's a great question. And Dr. Hodgkins from Gateway says, I may have missed this, but is the site PI blinded or unblinded? I think in general, we would prefer that the site PI is blinded.
Yeah.
Because
More than preferred, you need to be blinded, period.
Yeah.
That's what I thought, but I just wanted to check because it will be well, it's not going to be confusing. It's just so if blinded, then like do the site PIs like in other protocols not have to sign off if we're going to do a protocol deviation because we have to unblind somebody?
So on the deviation form, we're still not going to tell what the treatment arm assignment is. We're just going to say there was an unblinding incident.
Okay, so that'll be fine then.
Yeah, yeah.
Same protocol then as in the past.
Yeah.
Okay.
Great question. Anyone else have a question?
I do. For team meetings and stuff, every week we have a team meeting where all of us get together. Should the unblinded physicians maybe not attend the meeting, or?
I think that may be a good idea. It's okay for the blinded staff to share information with unblinded as long as it doesn't impact outcome. You know, it's not outcome information. But I think in general, the two sides should avoid talking to each other as much as possible.
Yeah, I mean, if there's a specific issue, like with the trade-off between, the blinded and unblinded staff that you need to resolve, and you want to invite them to one of the meetings to discuss that specific topic, that would make sense. But otherwise, yeah, it's slip-ups are just too easy.
Yeah. Okay.
Great questions. Any other questions coming up? How does the blind medical clinician determine if AEs, SAEs are related or not? The same way you would for any other study where you don't know whether the participant's on placebo or active medication. So looking, at temporal associations, the actual symptoms being discussed, all of the usual kind of stuff that you ask when you're trying to determine that question. Any others?